Good morning, everyone. I think we've still got some people joining the event on this early Monday morning. Welcome to today's Early Intervention and Psychosis event. This is the sixth in our series of events bringing you speakers who are well experienced in early intervention work both in Scotland and wider afield. So before I introduce the speakers today, I just want to run through some quick housekeeping with you. So this session is being recorded, but there will be no identifiable information. So your name and your faces won't appear on this, and it just means that we can share the recording later for people who can't make it. If you can also use your chat function, so if you have any questions for the speakers or any insights or any thoughts you have as the session goes on, please pop them into the chat box and we will pick them up at the end. We are also going to be running polls today, so there's a few questions going to come up on your screen. For those of you who are not familiar with polls, it will pop up just as you see it on the screen there as a little black box with a question and some answers. So the presenter will ask you the question, this will appear, and you can just click on the answer that you think and you press submit, and then you'll see a live tally of what the answers will come up as. So these are just some things we do to get some instant feedback from you. So that will pop up on your screen and it will also appear in the chat box. So just for today, the plan is we've got 3 speakers and they're going to present for the first hour, and then we will end with about half an hour of Q&As at the end. And just a bit of a background, so this event is on the back of a webinar that Dr. Turner had kindly done for us back in August, and it was so well received, and the feedback was that they would like a follow-up session, so hence the workshop today. So for too long, the physical health of patients with psychosis have been neglected, and this workshop looks to explore the causes of reduced life expectancy of service users and what can be done to combat this. And our speakers will explain how to screen and intervene for the modifiable physical health risk factors, and they will share examples of good practice. So our 3 speakers today, the first one up is Dr. Scott Ray. Scott is a consultant psychiatrist working in Esteem, which is the Early Intervention and Psychosis Service in NHS Greater Glasgow and Clyde. Scott's particularly interested in the physical health side of EIP and the interplay between physical health and psychosocial aspects of recovery from first episode psychosis. He's also part of the physical health group within Esteem and has been working to improve monitoring and interventions within the service. We then have Dr. Erin Turner, who you may be familiar with. She's a consultant psychiatrist with clinical lead in Solihull Early Intervention for Psychosis Service. She is head of the Psychiatry Teaching Academy for Aston and Birmingham Medical Schools, and her textbook, Recovery from a First Episode of Psychosis, was co-authored with the UK Early Intervention Pioneers, and this focuses on symptomatic and social recovery from psychosis. And finally, we have Luke Rose. Luke is a senior health instructor for Solihull Early Intervention, and he's one of the first health instructors to have been recruited to work within a community team within Birmingham and Solihull Mental Health Foundation Trust. So we're really looking forward to hearing from all these speakers today and hope that you can engage with some questions for everybody. So now I'm going to hand over to Scott to kick us off this morning. So over to you, Scott.
Thank you very much. Can I just check you can hear me?
We can hear you.
Good. Okay, so before we started this, everyone, we'd had a little technological run through, so I'm just going to make sure I'm doing this properly. I've taken control. Good, that's working, I think. Thank you for having me along today. And as already said there, my name's Scott Ray. I'm one of the consultant psychiatrists within Esteem, the early intervention service in Glasgow, and with a particular interest in the physical health side of things in early intervention. So the way we decided that we would kind of run this is I'd go through a bit of the background to physical health stuff, and then perhaps the more interesting and important part of interventions will come afterwards with Helen and Luke. But I don't. It doesn't make anything about what I'm going to say any less important. I have a particular interest, as I said, in physical health and can get a bit carried away with it. And so I've tried to make this as non too sort of technical as possible. And I'm not entirely certain of the audience I'm talking to. I don't think it's um, too many medical or psychiatrists here. So I've tried to pitch this at a level that anyone can understand. So apologies if it's too simple. Apologies if there's parts that are too complicated. But maybe the Q&A session at the end we can use if anyone's wanting to pick up on any point. Um, okay, so as Ashley was saying, we're going to I'm going to start this off with a few questions just to get people's brains into physical health zone. And don't worry, I know audience participation makes people's hearts sink, but there's nothing like what you imagine. There's nobody's going to have to speak up or anything. These are just a few questions to get your mind working. 5 questions, and I'll tell you the answers after we've gone through each one. So the first one, how much shorter is the life expectancy for people with psychosis compared to their peers? A, B, C, D, or E, 5 to 10 years, 10 to 15, 15 to 20, 20 to 25, or 25 to 30. And hopefully that has popped up. It certainly popped up on my screen now. So if you click what you think the answer is and then click submit. And excellent, I can see everyone's obviously doing it. And just giving it a couple of seconds to let you all have a chance. And congratulations, everyone. 42% said 15 to 20 years, which is the correct answer. Um, which is still shockingly high. And I'm going to come on and talk about all these things throughout the presentation anyway. Right. Next question. Which of the following is not a feature of metabolic syndrome? And don't worry if you don't know what metabolic syndrome is, I'm also going to talk about that. Um, obesity, smoking, hypertension, dyslipidemia, or insulin resistance. And remember, it's which one is not a feature of metabolic syndrome. Two seconds, my computer has gone into standby, but I think I'm still here. Okay, maybe these questions were too simple because you're all doing very well. Smoking is the correct answer. Partly put this question in though because it's to highlight that smoking is not something that we can forget about just because it's not part of the metabolic syndrome. Next question, which of the following antipsychotics is associated with the least amount of weight gain? Olanzapine, risperidone, aripiprazole, quetiapine, or clozapine? And very good. Oh, still very good. Aripiprazole is the correct answer at the least amount of weight gain. Olanzapine and clozapine are the ones with the most amount, sort of highest risk. Risperidone, quetiapine, medium, aripiprazole, low. Next question. What BMI cutoff score is considered obese? That's interesting. That one's a bit closer. The correct answer is over 30. So over 25 would be considered overweight, but then over 30 is obese. And again, that's going to pop up later and I'll talk about that. And final question, what percentage of first episode patients, so patients with a first episode psychosis, smoke? 15, 30, 45, 60 or 75%? And yes, the correct answer is 60%, which I think is still remarkably high, and a big cause of concern. So good. That went extremely smoothly. I was a bit worried about a technical inclusion activity there. So thank you very much, everyone. So I'll move on now um, and start presentation. So as Ashley sort of started off by saying, for too long, physical health within mental health services has taken a back seat or gone under recognized, under treated, etc. Which since throughout my training has always been the message. Um, and is part of the reason I'm very interested in it. Whilst working in an early intervention service, because I think even though we still hear that message and still say it, and perhaps we're getting a bit better at it, I don't think we're nearly there. I think any of us here today, whatever service we work in, can't really stand up and say we've got this right yet or we're on it. Um, and especially in early intervention services, when people are so acutely unwell, particularly at the start, we focus all our energy on getting them symptomatically better from a mental health point of view. Um, and when we're considering risk, I mean, whatever area of mental health we're working in, we are all considering risk. I think it's one of those things that gets hammered into us. Um, Perhaps we're always thinking of risk in terms of risk to self and others, but in terms of risk of suicide, self harm, etc. Um, we're not necessarily always thinking, oh my goodness, what are their cholesterol levels? Or even just physical health, generally speaking. Um, and in early intervention psychosis, which is what these talks are all about, is in fact of paramount importance because this is the time in their mental health journey, so to speak, to really be intervening early and trying to make longer term physical changes. Um, so here are just some pretty horrible figures, but unfortunately true. So young people with psychosis have significant health inequalities compared to their peers, up to 3 times higher risk of cardiovascular disease, up to 3 times higher risk of type 2 diabetes, 4 times more likely to be a smoker, and they're far more likely to have unhealthier diets or not meet the uh, recommended exercise targets that we should be meeting each week. So ultimately, put all that together, and you get the horrible figure that people with psychosis have a life expectancy shorter than 15 to 25, 20 years compared to their peers, which um, personally, and I don't know if anyone else here working in early intervention and psychosis, it's not really in your mind because our patients are young and you're not thinking about that far in advance. But now, since with my interest in physical health, I now look at patients as soon as they come in the door. And if I'm accepting them and they're psychotic, then I think straight away this person's essentially lost 20 years of their life if we don't do anything. Which is a pretty horrible way to think, but I think you have to look at the figures which speak for themselves. Um, the causes of those horrible figures and health inequalities in people with psychosis are well, multifactorial and pretty complex. I think the first and, to be honest, main big thing that comes to mind are lifestyle factors, and what we talk about and what form the mainstay of interventions, to be honest, which will come later when Erin and Luke are talking. But um, that being sedentary lifestyles, smoking, poor diet, etc. But you also have to factor in illness factors, particularly in people with psychosis, so negative symptoms, for example, or depression, which we know is very common as well. Um, the sort of post-psychotic type depression that people get. Um, Genetics, of course, people from certain ethnic backgrounds, for example, people, well, we're all guilty ourselves, people from the west of Scotland are at higher risk. And of course, the big one, working especially in psychosis, medication, especially antipsychotic side effects. So we ourselves can be guilty of contributing towards this with our medication choices. And it's important to note the general health of the, we know this from the media and the news, etc. The general health of the population with or without mental illness is getting worse with higher levels of obesity and diabetes. Um, so patients, whether they've got psychosis or not, things are getting bad in the general population. To for us to then come in and start adding in antipsychotics and things, we're sort of creating a recipe for disaster. Hence, all the more important for taking this so seriously. Um, and the big thing, I suppose, I think we are getting better at screening for physical health, um, with bloods and physical parameters and so on. But our communication with GPs is of absolute paramount importance. There is this risk that GPs will assume that because we're doing that, that we're dealing with it. And equally the other way around, we assume that we might be doing it, but assuming that the GPs are the ones dealing with it. So we have to communicate with them to make sure that patients are getting access to the right evidence-based treatments for any physical health abnormalities. So, what causes the premature death? So why are people dying up to 20 years earlier? And the straightforward and main answer is cardiovascular disease. This is the biggest killer. Um, it's we know that cardiovascular disease is the biggest killer in the Western world anyway, but remember these patients we're talking about are dying up to 20 years earlier. Um, when we say cardiovascular disease, we're talking about heart attacks and strokes mainly. But the underlying sort of mechanism or pathology for that is atherosclerosis. I asked a psychology colleague the other day, and this is when I was concerned I was going to go down a real medical rabbit hole and lose people. Um, I asked a psychology colleague, if I say atherosclerosis to you, do you know what I mean? And he said, yes, hardening of the arteries, I think. So I thought, great, okay, yes, you kind of do. So without going into the technical detail, because I remember at medical school having to know this in the most minuscule of details, essentially atherosclerosis is narrowing and hardening of our arteries. Um, Athero is soft or porridge-like, and sclerosis is hardening. So atherosclerosis itself is essentially a combination of atheromas, which are fatty deposits in the walls of our blood vessels or arteries, and sclerosis, which is the hardening part and stiffening of the artery walls. So our arteries, the blood vessels that take blood away from our heart and around the body, delivering blood and oxygen to all our um, organs, should be nice and elastic and expandable. But with atherosclerosis, they get narrower, harder, and less expandable. the heart then needs to pump harder to push the blood through. Our blood pressure is therefore higher. Um, the narrowing of the arteries means that blood can't get through as easily to all our organs. So when that happens in the heart, you get angina. If it happens in the brain, you get mini strokes or transient ischemic attacks, if anyone's heard of that. But it can happen anywhere in the body, so it can happen in the legs. People, typically older, longer term smokers, will get something called intermittent claudication, which is essentially angina in the legs, where they get painful legs when they can't get enough blood flow through to them when they're walking or running, for example. Um, these fatty plaques that develop and narrow the arteries, um, the real risk is when they rupture and they can fire off clots and combine with platelets in the bloodstream and form uh, chunky clots that can basically uh, obstruct the blood vessels altogether, and you get no blood supply beyond that point. And that's when you're in serious trouble. That's when you have your heart attack and your strokes, etc. Um, so, if cardiovascular disease is what um, leads to the death of our patients, um, what causes cardiovascular disease? And that is a variety of things, but the big thing is metabolic syndrome, which is what I was alluding to earlier in one of our questions that we did. Um, and the easiest way to think of it is metabolic syndrome is accelerated cardiovascular disease. So it comprises four things: insulin resistance or diabetes, weight gain and obesity, dyslipidemia, and hypertension. And people with psychosis by the age of 40 are 2 or 3 times higher, a higher risk of having already got metabolic syndrome compared to the general nation. So this is where a lot of our physical health monitoring and interventions are. That is what we're trying to target. Um, so I am a big fan of a graphic to visualize things. So if you imagine perfect health over on the left-hand side, I'm sure we can't all relate to the picture of this man, but imagine that is 100% perfect health, and on the right-hand side is end point, your cardiovascular ending. Not to sound pessimistic or depressing about it, but a stroke or a heart attack. And cardiovascular disease is the journey to that. And so if you imagine metabolic syndrome, as I just said, is this um, ball of overlapping metabolic abnormalities that gets you quicker and quicker towards that. So our job is to help patients stop it in its tracks, or at least even try and push it back, but at the very least, stop it developing further. And I should say that these metabolic abnormalities um, all overlap. And so, as I sounded really intelligent and smart today, I was trying to read up on how they physically make atherosclerosis worse and how they overlap and things. And I almost wish I hadn't tried, because it is so complicated and way beyond what we need to know for within mental health services. But just know that they do um, overlap, and one thing is not necessarily come without the other. So I'll briefly go through each in turn of those things, before we come on to Erin and Luke, who address sort of how we can tackle them. So weight gain and obesity, this is the big thing, and of all the sort of features of metabolic syndrome, this is the thing you can see, and this is the thing that patients get upset with, quite understandably, but considering they're young first episode patients. Um, one of the most rewarding things about working in early intervention is that patients are receptive to antipsychotic medications and they work. their symptoms tend to get better, even on the first antipsychotic you try. Um, However, they're also more sensitive to the side effects and weight gain very much in particular. Anyone that's seen a young first episode patient get olanzapine will know that you see them gain weight rapidly and quickly. And weight gain tends to be most rapidly at the very start, and within the first few weeks, and then plateaus in the months thereafter. Um, and understandably, that can affect patients' mood, confidence, and I suppose, in a kind of selfish point of view, from us, medication concordance. You can understand why they would want to stop taking their medication, particularly if their symptoms of psychosis improve. Why would you want to keep taking a medicine that's making you gain weight? So frequent weight monitoring is important, especially at the start when people are gaining weight most quickly. And that's the point when we can intervene most early and to try and mitigate it. Um, we talk about early intervention in psychosis, but this is why I think early intervention in physical health is so important. Um, NICE recommend that we weigh people every week for the first 3 months. I'm sure pretty much everyone here can say we don't. Um, but part of that has to be pragmatic. I think you'll really put patients off if you try and weigh them every week for 3 months. Um, so you need to kind of meet somewhere in the middle. Um, I think what's quite interesting is why do people gain weight? And this is often what patients or families will ask you. Um, and we are, hands up myself, quite guilty of saying that the medications make you hungrier, and they do make you less full, so you eat more, um, and that is to a large extent the truth, but it is more complicated than that, and the antipsychotic medicines do act at specific receptors that can just make people gain weight. Um, so that 5-HT2C, that's a specific type of serotonin receptor, and H1 are histamine receptors. So antipsychotics acting on those and also reducing people's sensitivity to leptin, which is a chemical that tells you are full. Um, so with the antipsychotic acting on that, hence you feel less full and keep eating. And body mass index, that was an interesting one when we asked the question there. Um, Most people know. So body mass index takes your weight and height into a calculation. And a healthy BMI would be between something between 18.5 and 25. Over 25 is overweight. Over 30 is obese. And I think over 35 is termed morbidly obese. Um, Dyslipidemia, I'm just conscious of time, so I'm not going to go into too much detail. Don't get bogged down by how detailed that slide is. But I think dyslipidemia is an interesting one because we talk about lipids all the time, but and get all this triglycerides and cholesterol and things, but what's what? Essentially, lipids, um, there are lots of different types. Um, they have lots of different functions in the body, but the main ones from our point of view that we want to know about are triglycerides and cholesterol. Um, Triglycerides, by far the most common type of lipid in the body, they give us energy, um, can be saturated or unsaturated. Saturated just means that they are solid at room temperature, they're normally animal derived, and unsaturated, that's they're usually liquid at room temperature, oils and things. Um, and that is some of those can be healthy. So the omega-3 fatty acids, that's why I'm mentioning this because we've all heard of that. And they are in fact healthy, good fats, should I say. Um, Cholesterol, we think of cholesterol as a bad thing. It's not there, it's used for other things in the body. But it can be when it comes to LDL, cholesterol, which I'm just about to mention. Um, so when we eat, and if we eat too much our extra calories are stored as the fat that we see, our adipose tissue. Um, Triglycerides and cholesterol, they're not water soluble, so they can't um, travel around the body without binding to proteins. So they're carried around by proteins and create these things called lipoproteins. Lipo meaning lipid, protein. Um, and that's when you get your HDL and LDL, which are high density lipoproteins and low density lipoproteins, which I'm sure people have heard of. HDL being your good cholesterol and LDL being your bad cholesterol. The HDL is good in that it takes cholesterol away to your liver, deals with it there. The LDL cholesterol is the bad one and deposits into the blood vessel walls, leading to the atherosclerosis, which I talked about earlier, and ultimately cardiovascular disease. Hypertension or high blood pressure. Um, High blood pressure directly caused by antipsychotics is relatively rare, um, but it is well, it's sort of termed the silent killer, hypertension, because you can't see it, um, but it can lead to all sorts of problems. Hence why we monitor it. Um, and I'll leave out interventions because that'll be coming up afterwards. Insulin resistance, diabetes. Insulin resistance is what sort of comes before diabetes. As we all know, when we eat, our pancreas releases insulin, which helps glucose get into our cells, and our blood glucose levels return to normal. If we live chronically bad lifestyles, poor diet, lack of exercise, etc., we've always got high glucose levels. Our pancreas is always having to release insulin. It gets tired. It pushes more and more insulin out, um, to the point it kind of packs in, and the cells in the body become resistant to it. In terms of monitoring purposes, um, in Esteem, certainly, we've stopped doing fasting glucose levels. The practicalities of doing it were it was too difficult to always try and to do. So instead, we measure HbA1c, which often people are doing as well as fasting glucose in other areas. And people have probably heard of HbA1c. It stands for glycated, well, it doesn't stand for it, it means glycated hemoglobin. So hemoglobin is what's in the uh, red blood cells in our blood, and that's what carries oxygen around. Um, Red blood cells, it gives a sort of measure of how what your glucose levels have been over the past 3 months. And red blood cells have a lifespan of 3 months. That's why it's that length of time. Um, so if you've got too much glucose in your bloodstream, it sticks to the red blood cells, hence why it's a good indicator. Um, and I'll not go through the figures, but essentially you want it to be lower. The lower, it means the less glucose in your blood, really. Um, and what causes metabolic syndrome? So if cardiovascular disease is what kills and metabolic syndrome causes cardiovascular disease, what causes the metabolic syndrome? And it's lifestyle for the most part. Um, Smoking, poor diet, and exercise. Um, Smoking is bad. We've heard that forever, essentially, well, throughout most our lifetimes. Um, it's not part of the metabolic syndrome, but it doesn't mean that it should be ignored. So, smoking itself can lead to changes in the body that lead to high blood pressure, which of course feeds into metabolic syndrome. But even the chemicals themselves within cigarette smoke can act directly on the blood vessels. So nicotine, for example, at a cellular level can directly cause atheromatous plaques to be forming. So it's it's not good at all, and I think we're all guilty of probably not really addressing it with our patients. Um, but as I said earlier, the causes of all these things overlap and are multifactorial. Genetics. I work in the south side of Glasgow, which has a high South Asian population, and there's a massive history within families. They've always got relatives that have got diabetes, or their grandparents died early from heart attacks and so on. And as I said, the antipsychotic drugs themselves can contribute to changes leading to increased risk of metabolic syndrome. That's my final slide, just to hopefully I've highlighted how important it is that we address physical health, particularly in early intervention in psychosis, when we have that opportunity to intervene early and try and create longer, lifelong changes. Yes. Okay. Sorry if I spoke at rapid pace there, but I was aware that I've got two more people that want to speak. So I'm going to hand over to Erin now.
Hello, I hope you can all hear me. Someone give me a thumbs up if you can hear me.
Yes, we can hear you.
Okay. Hi, everybody. Thanks, Scott, for that really helpful sort of overview of what metabolic syndrome is, and for highlighting the risks associated with poor physical health in early intervention. So just a little bit of background from me. I've worked in early intervention services for nearly 20 years. And I, like Scott, have usually led on the sort of physical health interventions in early intervention. And it's quite a difficult process. I think it's getting better, but back then, when I first, came into early intervention, it was really hard to get people enthused about physical health. So, the mental health team and psychiatrists who very much felt it was the GP's domain to monitor and intervene for poor physical health in psychosis. And maybe it's because I initially trained as a GP, but I'm also married to a GP, and I'm really aware of how GPs have generally expected the psychiatrist to do. If they're prescribing the medication, it should be the psychiatrist to do the monitoring and management. And actually, it's probably somewhere in the middle. I think, as Scott has said, it is really important to have dialogue with the GP to work out who is best at managing the physical health difficulties that arise, a lot of which are compounded or caused by the medications that we prescribe. But what's really important is to establish who is doing what. And again, over the years, what I have found is it is easier if we do it in-house, the monitoring and screening. And then if if we need the GPs to do the intervention, then we certainly liaise with them and ensure that they're doing that. So what I would suggest is that if your team can be set up to do the screening and make sure that you've got really good process for ensuring that you don't just screen, but you actually look at the results and then you work out an intervention as a result of that. That is really, really important. And again, it's, I've worked in lots of different teams that have got a lot of different approaches. We've had spreadsheets, et cetera, et cetera. But actually, I think that what we've got now in place in solely intervention seems to work really well. So hopefully you'll be able to pick up some tips, but that's not us saying we've got it right. But what I'm trying to say is it's been a long process to get to this. And it's, at times it can be frustrating because it feels that people maybe don't focus enough on physical health of our patients. And I think, as Scott has rightly said, that their life expectancy is so much less. That is, our business. Okay, so I'm hoping that you've all had the Helen Lester positive cardiometabolic health resource that she developed. Helen Lester was a GP working in Birmingham who worked very closely with early intervention. She did a lot of the early research with Max Birchwood and the Birmingham early intervention team, and she was very keen to educate GPs on the importance of picking up these early warning signs about metabolic syndrome. And then, you know, we had a lot of discussions about should it be psychiatry or general practice. And I think generally it was agreed that, you know, we should be doing it in-house psychiatrists. And so I find this health resource really, really helpful because she goes through the different, you know, she's highlighted the really important components that need to be screened for if we're going to pick up metabolic syndrome. Because it is all about intervening early, not just for psychosis, but for the physical health difficulties. So if you don't have a copy of that, please make sure that you speak to Andrea or whoever else in NHS Scotland and get that emailed out. I've got quite a few of these in my office, laminated. I always give it to our junior doctors and get them involved in this really important area. And again, just a bit of background for those who came to my webinar. You know, I think some of these slides are repeated, but I don't make apologies for that because I think this is really important to be aware of. So we know that historically, physical health has been the physical health difficulties have been under-recognised, you know, for a long time in psychiatry, and this was highlighted back in 2014 with the National Audit of Schizophrenia, and they found that sort of only a third of patients with schizophrenia had their physical health monitored appropriately, and you know, I think this was, again, it's not just the difficulties with us in mental health, recognising the importance of monitoring it, but we know that our patients often have difficulty accessing primary care and other secondary care areas with their physical health problems. So, you know, not only is diabetes maybe not picked up quickly enough, but actually they're not accessing the right services to get it managed properly. And so on the back of that has come the sort of the clinical audit of psychosis, where physical health plays a really important component. And I know that your early intervention team in Scotland isn't part of this, but the hope is that you will become part of this audit, because I have found that this has been almost the turning point for improving the physical health care in our patients with first episode psychosis. So, you know, it is, you know, I suppose a bit of a sad indictment that it needs an audit for our results to be displayed, and that sort of competitiveness, looking at other teams, oh look, they've got 90% in their physical health, we've got to improve. But actually, you know, the thing it has done is it's really highlighted the fact that we don't have an option. We have to monitor the physical health and not only screen for it, but we have to intervene. And as a result of this audit, we can see the results have increased. So back in 2018, when it was first introduced, on average, that 64% of the patients that were audited had all their physical health, you know, screens done. So that's the BMI, blood pressure, lipids, etc., glucose. But only of those that were abnormal, it was only about half of them actually had an intervention for those. And so the results from last year have shown a steady improvement. So we're getting up to 80% of our patients audited have been screened and now intervening on 71%, which is massive improvement. Obviously, there's still room for improvement, but it does highlight the importance of auditing. And you don't need to be part of a national audit to do your own internal audit of how many of your patients are screened and intervened. And the reason that we have been able to improve that in our team is that we do a 6-monthly MDT review of each patient. And again, a key component of that review is that the care coordinator has to ensure that they have had a physical health screen in the preceding 6 months. So they usually do it the week or two before that MDT review. And in the review, there's a doctor there in that review who then, looking at the physical health results, will pick up if there's an abnormality and then put in an intervention. And we'll come on to look at some of those interventions. So if your team's not doing it, screening, it is very easy. You just need to get the right equipment. So obviously we need to check that, we need to know their BMI. So we just need a weight machine with height monitor attached. We need a sphygmometer, and we need to have access to doing blood tests. So looking at the lipids, and as Scott says, the HbA1c is a much better way of screening for for pre-diabetes and diabetes. And then an ECG is important. You need to do an annual ECG. And then it's just a case of filling out your forms, focusing also on smoking and substance misuse, because they play a huge part in the reduced life expectancy. Okay, so I'm just going to run through quickly the interventions that Scott has highlighted. And by far the most important one that people will often recognise is weight gain. And as he has rightly said, olanzapine and clozapine are the worst proponents of weight gain. So it's really hard to reverse. Obviously, prevention is important, and doing a weight. So obviously, I don't think anyone does weekly weights. I don't think it's good to do weekly weights for somebody in their recovery. But I think certainly at baseline, and at the very least, again, at 3 months. And then at that 3 months, you need to make that decision. Do we continue with this medication if they have gained weight? So I would say if they've gained more than 10 kilos in weight, you need to look at potentially changing that medication, which is likely to be sort of olanzapine or quetiapine. We'll come on to talk about clozapine in a bit. Clozapine isn't one that you would change due to weight gain, because again, on balance, the benefits outweigh the disadvantages of weight gain. So a change of medication would be the first, I guess, and it's not easy to change medication. Clearly, if somebody is on olanzapine and their symptoms have really improved, and if they choose to stay on it, then what else can we do to reduce the weight gain? Clearly, diet and physical health is important, and Luke will come on to talk about that, how we've kind of tried to address that in Solihull. But again, for people who have got a lot of negative symptoms and they're unmotivated, it can be a challenge. Sometimes if they don't want to change their medication, we could add a small amount of aripiprazole, and there's not large random control trials, but the evidence is for the smaller ones that there is some modest weight loss when you actually add a small dose of aripiprazole to your antipsychotic. So it is a difficult one, but I think recognizing it and speaking to patients about it is really, really helpful, not sort of brushing it under the carpet and pretend it's not there, because it's a significant obstacle to their recovery. Very similar with dyslipidemia. So make sure you monitor for it, you've identified it, you speak to your patient about it, and then talk to them about lifestyle changes. We talk about the good fats and the bad fats, and the good fats generally, a Mediterranean diet has always been sort of promoted as healthy, because moving to from to olive oil, really, from butter, something like that, trying to reduce your cheeses, trying to change from white bread to brown bread. So simple dietary advice that any of us can do, and very helpful. I think patients actually appreciate the fact that their mental health team is also interested in their physical health. Again, promoting physical exercise. And when do statins come into it? Statins kind of have gone out of favor, but I think they were maybe overly promoted and overly marketed. What statins do is, particularly if you're very high in the wrong lipids, the sort of low density lipids, is they actually reduce the production of sort of cholesterol and lipids. They do have side effects. So people will often say that they feel quite bloated on statins, and sort of get sort of disturbed, gastrointestinal sensations. They don't feel good on them often. But I think if the lipids are really high, particularly if there is the familial hypercholesterolemia, actually statins should be considered, particularly, if there's other concerns about their cardiovascular risk, they're smokers, etc. So again, that's something probably to discuss with GP. Certainly if their cholesterol level is higher than 8, I will discuss with GP and say, do you think we should think about starting a statin? In the same way, sort of insulin resistance, if their HbA1c is over 48, that is diagnostic of diabetes. And so again, I'll speak to GP, do you want me to speak to them about the diabetes, or would you rather do it? And we'd get them plugged into seeing their diabetic nurse in the GP surgery to talk about commencing a medication, such as metformin. Pre-diabetes is really, really interesting. And so it's always important to pick it up and feed that back to the patient and say, look, you are in that risky area. So between 42 and 48 HbA1c. So you are in that pre-diabetic range. There's plenty that you can do that will reverse it. And a lot of evidence that will suggest if you can make lifestyle changes in this area, you will be able to reverse it. And that is around changing your diet, reducing your junk foods, your sugar content, increasing your physical activity. But there's a lot of debate about starting a medication like metformin. Metformin makes the body more receptive to the effects of insulin, so insulin becomes more effective. So it almost kind of reverses that insulin resistance. And is there an argument for starting metformin in that pre-diabetic range? Now, a lot of the GPs I've talked to have said, yes, actually there is a good argument for that. I've had patients where they've wanted to start metformin in that pre-diabetic range and the GP hasn't. So, it's around sort of liaising with GP, but also taking the patient's views into consideration. But I would suggest if you're thinking about starting metformin in that pre-diabetic range, it would only need to be done as part of a full program of, increased physical activity and changing diet, and probably after that has been trialed. And I've had patients who've managed to get out of that pre-diabetic range really effectively just through diet and physical health change. Hypertension, management of hypertension is more tricky because it really depends on age, demographics, etc. That's one you definitely need to, if you're a prescriber, you definitely need to talk to GP about. But again, really important to pick up as early as possible because it is definitely associated with reduced life expectancy. So what we can do as a mental health team is talk about ways that they can do it through lifestyle. We know that high salt content is linked to high blood pressure, so helping people to look at their diet. We know that smoking and high lipids are linked to high blood pressure, as Scott very helpfully showed us about the atherosclerosis, the narrowed arterial lumen that can cause high blood pressure. So all the lifestyle dietary changes that we've talked about, that's really, really important to promote. And they will all, as Scott says, they all massively interact with each other. Moving away from metabolic syndrome, just a couple of things I want to sort of mention that is, I think really, really important again, and this is more linked to our prescribing, is hyperprolactinemia. Is it important to pick up? It is important to pick up because there are some sequelae linked to hyperprolactinemia. So it's basically when the prolactin level is higher than 424. And it is caused generally by dopamine blockade in the pituitary gland. And the medications that cause the more dense dopamine blockade are more the first generation antipsychotics. And those second generation antipsychotics, which are closer to first generation, like risperidone. So risperidone is a real culprit for hyperprolactinemia. Usually it is asymptomatic, but it can cause, for females, it can cause menstrual irregularities. It can cause lactation. For men, it can cause gynecomastia, so breast bud enlargement. It can also be linked to sexual dysfunction. So it is important to identify it. There's also evidence that if people have prolonged hyperprolactinemia, it can actually lead to some osteoporosis, so sort of reduced bone density and reduced fertility. So important to pick it up. And then how do we manage it? If it's really super high and patients have got some visual disturbance, then you might you need to exclude a pituitary tumor. So the pituitary is in between, in the brain. It's situated in between where our eyes are, and it can actually press on the optic nerve. That's why you can get visual loss in sort of your outer fields. So the doctor might want to refer on to exclude a pituitary tumor, but they're really, really rare. So commonly, hyperprolactinemia is caused by the medications that we're prescribing. So you might want to think if the patient's been stable on their medication, and you're able to lower the dose of antipsychotics, that might help. You could switch if you want to a medication that is much less likely to cause hyperprolactinemia. So certainly if they're on the first generation, move to a second generation. I often will add a very small dose of aripiprazole, 5 milligrams, or even less, 2.5 milligrams, which can be given in syrup form. And that has a really profound effect on reducing the prolactin level. And then finally, just looking at cardiac complications. I don't want to go into these in too much detail, but we do know that, as Scott has said, that antipsychotics are linked to hypertension. Sorry, there's a typo there, and arrhythmias, and high, particularly clozapine can cause tachycardia, very fast heart rate. Yes, orthostatic hypotension is linked to clozapine. That's why we really have to do, the pulse and blood pressure very frequently in the early stages of using clozapine in particular. But QT prolongation is the big one linked to antipsychotics, particularly sort of first generation, that's why it is really important to look at QT prolongation, because it is linked to arrhythmias, and some arrhythmias can lead to sudden death. It's linked to something called torsade de pointe, which can be linked to sudden death. So we really need to check it out. If the QTc is over 500, we need to absolutely stop or change our antipsychotic. And generally, as a rule of thumb, is the first generations are more linked to prolonged QTc prolongation. But very important for those of us in the audience who are prescribing is thinking about the link if we're adding in antidepressants, SSRIs. Sometimes the combination of the two of them can cause QTc prolongation. Sertraline is the one that causes that least, so that's the one that I usually use. So making sure we do an annual ECG, I think, as a minimum, is really, really important, and look at the QTc. And try to avoid polypharmacy where possible. I know I've just talked about adding in a small dose of aripiprazole if they've got hyperprolactinemia, but aripiprazole is the one that's sort of least linked to any cardiac complications, and if using low dose, it should be okay. But I would suggest, for those of you prescribing, make sure someone has an ECG, particularly if they're on more than one antipsychotic. Okay, so I've talked about changing to different antipsychotics and avoiding citalopram. That seems to be the SSRI that is most linked with QTc prolongation. As Scott has said, 60% of our population do smoke. Really need to have a good smoking cessation intervention that patients can access. So sometimes we have nurses that can come in who are actually they lead on the smoking cessation interventions. They can prescribe the sort of nicotine replacement therapies, which can be given in different formats, as in patches, gum, etc. But really important to identify and to educate, because I think generally when I first came into psychiatry, it was just a given that everyone smoked, and that included most of the staff as well, who saw it as kind of a good engagement factor to go out on smoking breaks with patients. And we've come full circle of that. We've realised, that it is very important to promote healthy lifestyle with our patients. And sexual dysfunction, I have just put that in because it is often overlinked or sort of missed when we're reviewing patients who are on antipsychotics. Please do remember to ask them if they are having sexual dysfunction, because for our male patients with first episode psychosis, that is the common reason why they stop their antipsychotics. If they're on oral antipsychotics, is because of sexual dysfunction. It might not be caused by the medication. It's often just the illness itself, but we do need to ask, and there are, we can look at their prolactin if they've got sexual dysfunction, consider a change of medication or addition of aripiprazole, and consider medications that actually we can prescribe that can improve the erectile dysfunction. I've just put this in because there was a question from, I think it was the lived experience group, that they wanted to know about autoimmune disorders and psychosis. Again, I'm not going to go into this as much detail, just that there is a link between autoimmune disorders and psychosis. There's a lot of interest in inflammation in the brain, and it's linked to psychosis. We've had a lot of trials looking at, do antibiotics help with symptoms of psychosis, particularly the negative symptoms of psychosis, by reducing any inflammation in the brain. Large-scale trial looking at antibiotics actually didn't show any significant improvement, but there's a lot of interest in research in this. And of course, we know that the link between autoimmune encephalitis and psychosis is well understood, and we need to screen for that if we've got any, if there's any red flags that somebody might have an organic psychosis. So we're looking for those NMDA autoantibodies. Okay, I've banged on enough about physical health. I'm going to hand over now to Luke, who is our physical health instructor. And we're very excited about having a physical health instructor. I don't know if we're the first early intervention team who has got one embedded within the team, but we've really enjoyed working with Luke, and he's made a big difference to a lot of our patients. So over to you, Luke.
Oh, thank you. I think that's working now. Yeah, so just on the back of what everyone was saying, really, I'm Luke. I'm clinical lead health instructor for Solihull Early Intervention Service. I'm going to try and keep it short and sweet, just covering some of the key roles of what we've done as a health instructor service within early intervention. So moving on. So we initially set some new aims. As a role was new last year, it never been done before. I was one of the first health instructor to become in the team. We set some basic aims around patient engagement, overcoming barriers that service users had previously highlighted to the team, and some of those barriers around stopping them improving their physical health. So we looked at educating links between physical health and mental health. Addressing barriers to engagement using different approaches and techniques to combat that. Being able to offer session, activity or program-based interventions based on what service users had reported that they wanted to be involved in, or what they thought would be beneficial to themselves, such as keen hobbies, interests, or maybe just something new that they hadn't yet experienced or been able to try. And that sort of links onto the next one. So ensuring sort of service users long-term adherence around behaviour change, making sure that activities remain enjoyable, to look at long-term adherence and to continue to help with their physical health for the foreseeable future. So they were sort of the main aims we'd set. Obviously, there a lot more went into it around the physical health markers side, where we work closely as an MDT team with support workers, link workers, etc. So one of the first steps we looked at was engaging service users, which shown a few challenges as we looked at educating staff as well, especially as the role was new. It's very unheard of. But we tried to combat this by looking at team-led carers evenings. So we used to do carers evenings where people would come along, we'd do presentations, look at the role of a health instructor, the impact it can have within physical health and mental health, as well as sort of social settings. We've done a few presentations towards the team to help them understand the role, and other teams within the trust to help network and sort of expand the health instructor role elsewhere. We looked at the first few weeks, if not months, completing joint visits with CPNs to increase awareness of the role, as well as helping introduce myself to service users. And as that came across quite beneficial, almost having that link. I mean, we work with people for up to 3 years So some of our service users had already been under the care of a care coordinator for 2 years. So having them on board, understanding the role fully and aiding in the introduction of a health instructor to them was really beneficial, and not only helped that break down the initial contact barrier, but also helped initial engagement as well, by seeing that other members of the team were fully supportive and fully behind the sessions. We used accessible resources to aid in sort of further education around guidelines and promotional material. So on the back of this, we looked at highlighting 4 key barriers, which were physical, social, psychological, and technical. I'm not going to read through the whole list, I don't want to bore you, but as you can see, we looked at effects of medication, change in appetite, anxiety patterns, the list goes on, fear of being judged, so the whole stigma and trying to break down the stigma in social settings, finding it hard to leave the house, we've got a couple of agoraphobic patients, difficult in group settings, etc. Psychological and technical as well. So looking at community programs, not understanding an individual's needs, and that sort of links back into the stigma we found a lot of external providers had, unfortunately. So we went on to how we can overcome these barriers. So like I touched on, I won't touch too much on, is working closely with service users, using motivational interviewing techniques that we had previously been trained on within the trust. We looked at smart goal setting, positive reinforcement, peer support groups where some of our service users would all have the same keen interest, and we would look to introduce them within social settings, and building peer support groups on the back of that. Behaviour change models. So really focusing on getting people from that contemplation to pre-contemplation to action. Those 3 were initially our highest priority because we found that to be the biggest leap. And then supporting service users one-to-one as well, not just highlighting a problem, but actually offering a solution to that problem. So on the back of this, there was a couple of personal challenges. One of the biggest ones for me, and what others might find, is increasing staff awareness, especially to a new role. We fall under the AHP umbrella, but we are not as well known, should I say, as occupational therapists, physiotherapists, your speech and language. So not only introducing a new member of staff, but introducing a new role and getting that educational aspect I touched on earlier was quite a big barrier. But the team here has been really welcoming and were very keen and enthusiastic to get on board, which made my job a lot easier. Another thing was reducing the stigma attached to the word mental health when liaising with external providers. And I found that when asked sort of what population of mental health we're working with, and when we mentioned first episode psychosis, we actually saw quite a lot of facial reactions, which then brought on additional work and additional challenges that we had to break down to reduce. And then the last one was starting with a blank canvas. Like I said, the role was new last year. I've been in post just over 18 months now. And as nice as it is to walk in somewhere with a completely blank canvas, it's also daunting because the ideas and suggestions of what to do, what can we do, what do we have access to, resources is mind-blowing. So it was really around trying to narrow that down and getting buy-in from staff members. So we went on to session accessibility. So it was almost creating a menu of what was available of readily accessible sessions within the community. Peer support networks, like we touched on earlier, with the help of Mind and other places. Bear with me. We looked at peer support networks with Mind and local links, as well as setting up our own peer support network and health instructor-led sessions, as I touched on. Creating links with external providers to increase the amount of sessions we can offer. And this not only increased the amount of sessions we offer, but it also took some of the workload off of myself, as rather than running the one-to-one sessions, we could look at external providers also helping with these. Creating links and the session costs, we'll come on to that shortly. And then finally, I just wanted to mention the SEIS Synergy Programme, which is our Solihull Early Intervention Service Synergy Programme, which I have to give full credit to Dr. Aaron Turner for the name, as it went out many of times and seemed to be the most favourable. So recapping on the session accessibility, we tried to put a plethora of activities on. Now, I could spiel off a list of many activities that are now readily accessible, from mountain biking to outdoor and indoor tennis to fishing groups, snooker groups. We've linked in with local professional football club Aston Villa, who put on women's football, walking football, all sorts of different activities, all the way to autism-friendly boxercise classes, and the list just goes on. So it's really looking at being able to not only secure these sessions, but looking at promoting them as well. And one of the key factors we found when promoting was the freedom of QR codes and how easy they are to not only promote a lot of information in such a small area, but also to get very key points across. Some of the barriers to that was obviously having access to smartphones. But yeah, I'll put a little snippet of our timetable together, which covers the whole menu of activities. So just touching back on our Synergy programme, which you can probably already tell by the excitement in my face, I'm very much for promoting and behind, and it has gone from strength to strength. So as a recap, it's created as a menu of accessible activities available to service users under our care, both external and health instructor-led sessions. We attached merchandise, which everyone loves a freebie. It was the uptake we had of it. It was amazing. So we had personalised Fitbits, personalised water bottles. We had goodie bags full of readily accessible information, as I touched on earlier, from government guidelines to British Heart Foundation, and so much more, backpacks, which ultimately increased the buy-in as well. So it was a win-win situation on the back of that, which really helped, and we are continuing to promote the Synergy programme here in Birmingham and Solihull. I mean, as an overview, from the health instructor role, we looked at service user engagement, and it all sounds good on paper, being able to offer all these timetables, QR codes, activities, sessions, referral pathways everywhere. But it was really looking to see how effective the role had been within the service. So we've done a very brief 12-month period overview. Now, it's hard in those 12 months. As I said, I've only been within the team 18. So reviewing a 12-month period was probably the furthest we could go, as we are still developing external links with providers, referral pathways into community, looking at long-term adherence. But the statistics speak for themselves, and I don't want to blow the team's trumpet that much, but it's doing really well. So we have, on average, 22 service users engaging in regular physical activity each week. The group sizes vary from 1-to-1 sessions, and then from 2 to 12 people. And then as a percentage, we looked at 84% of our service users that were referred to myself or the health instructor team for input are now doing more than the government guidelines of 150 minutes of moderate activity per week, which, as Scott and Erin were saying, it combats so many cardio risk factors, metabolic syndromes, and it makes a huge difference to people's physical health. And the main one for me, a lot of what I do is looking at long-term adherence. I don't want to create a program or a service within the team that people rely that much on, that if they get discharged, everything comes to a stop. So it was primarily focused and heavily focused on looking at the onwards pathway, the long-term adherence, the getting people to participate after discharge. And as it stands, we have 28% of those service users now completing physical activity sessions by themselves, whether that be gym memberships, swimming club memberships. We looked at PHB funding for getting people their own mountain bikes, peer-led walking groups, and so much more. And we're hoping that the next time we come to review this, I'd like to say that those numbers are only going to increase. And that was really, I've lost control of my slide. Oh, there we go. And that was really it. There's a couple of snippets from some of the sessions we've run. As I said, it is continuing to be a developmental role, and we are continuing to learn and take advantage of every situation we can to better the physical health of those experiencing first episode psychosis. And that's it from me. Thank you.
Many thanks, Luke. Thank you to all our speakers. That was really, really great presentations. And I think Scott really set the tone at the start by saying that somebody presenting could possibly have lost 20 years of their life, which I think is really quite stark in that reality of it. And, you know, that dialogue with the GPs being really important to see who should be doing what. And look, finishing off, that was a really great presentation. I think that the success of your role is one that would be interesting to see how that rolls out wider, and whether that's something that we can start to embed in our services as we move forward would be good to know. There is some questions in the chat box. I'm aware of the time. We've got approximately 14 minutes, but if I could have Erin, Scott and Luke turn their cameras back on, I will fire some questions at you, and I'll start from the top. I think it kind of went with some of the presentations, but the first question was, can it be reversed at all? And I think that was towards the metabolic syndrome.
I don't know if you want me to answer.
Yeah.
Scott, do you want to go for it?
I'm kind of wondering of parts of the metabolic syndrome, yes, of individual parts, hypertension, etc. In terms of the underlying thing I was talking about, the atherosclerosis, the narrowing of the arteries, no, unless I'm missing something huge advanced in medicine I'm not up to date with. But you can slow it down, and that's what all of these interventions we're talking about are trying to do. I suppose the other thing to notice, this isn't a particular thing in people with psychosis. We're all sitting here with atherosclerosis, sorry to tell you. It's just faster in people with psychosis, and as I said, obviously significantly shortens their life expectancy. So no, we can't reverse that, but we can certainly slow it down. Hence the need for these interventions. And just to say to Luke, I thought that was amazing. Your presentation was the shortest, but probably in some parts the most important in terms of the interventions we need to be trying to instill with people.
Thanks, Scott. Another one that came up in your presentation, Scott, was, is there an argument for prescribing metformin in conjunction with olanzapine and clozapine to mitigate metabolic syndrome?
Do you want me to take that one, Scott?
Yeah, that please, it's fine.
Yeah, I think there is an argument if somebody, well, I think particularly with clozapine, because you wouldn't want to stop clozapine if someone that, you know, is actually doing really well on the clozapine. You know, again, that's something I think you would need to discuss with the GP. I think if they've gained weight on olanzapine, it is worth trying to change to another medication like aripiprazole if their mental state has settled on that. There's not enough research in this area. I wish there was more, because again, I'm very interested in the prescribing of metformin in the pre-diabetic phase. And so I think there does need to be more research, and I think the jury is still out on this. But metformin is a fairly benign medication, doesn't have too many side effects, apart from a few GI side effects. It's pretty benign, and it does have very, very transformative effects for some people in reducing their HbA1c.
Can I just add to that, actually? I don't know, and I don't know, Erin, if you've had much experience. There's quite a lot of interest recently about using metformin for weight loss. Not just necessarily the pre-diabetes thing. The sort of evidence saying that if everything else has failed, you can use metformin. I think the results are modest at best. And some GPs can be a bit reluctant to do it because it's off license. I've once considered it and almost regretted it because the patient, as soon as they got the hint that they could take a medicine that might help them with weight loss, they just packed in everything else. So, but yeah, it is a sort of topical point.
I think, yeah, it's similar weight loss to aripiprazole. It's between 2 and 3 kilograms. The randomized control trials have. So, yeah, there is some evidence, but it would be hard to sort of justify, I think, for everyone who's gained weight on olanzapine.
Thank you. The next one, Erin, was under your presentation. Do you often see a winter slump in weight and metabolic control, and what are the options for managing this?
I'm not, no, I don't think I've ever seen there probably is a winter slump. I think we all probably gain a bit of weight in the winter, don't we? The management is just exactly the same, as it is for it's promoting physical exercise, talking to people about their diet, and sort of helping them, change their diet and stop smoking. So I don't think it needs to be any different through winter.
Yeah, thanks. And do you refer to occupational therapy or think of OT for these patients and increasing activities or daily living to combat weight gain?
Yeah, absolutely. I mean, I think if you've got an OT on your team, you're very fortunate. And I know that that's a really important role, but it's not their only role. That's why I think it is, ideal if you can have somebody like Luke on your team who focuses just on physical activity. Because I think OTs, they've got so many other roles that they can get involved in. But I think if you don't have a physical health instructor and you've got an OT, then OTs could be really, really helpful at looking at lifestyle.
Great, thanks, Erin. And Luke, this was under your presentation. How do you overcome personal stigmas about exercise from those you work with or engage with?
So like I said, it's always been an ongoing battle trying to break down the stigma, a lot with the external providers. I was quite fortunate that the team here were very forthcoming and very behind it. But I think being able to present from a health instructor's point of view, the importance of a link between physical health and mental health increased the amount of buy-in we had, rather than just labelling it as a term of exercise, was looking at breaking that down into what it actually meant to someone getting out of the house 5 minutes more a day, getting off the bus one stop early. And a lot of it was around that key information giving and breaking down.
Thanks, Luke. This is probably similar to that. How did you overcome the barrier? You mentioned, for example, a lot of mental health groups I've worked with don't have access or want to engage with info online. I'm just interested how you overcame this.
Very much so. So I've come across something very similar, and I think it helps being in the role. And if someone isn't wanting that online buy-in, we've been fortunate enough to be in a position where we can offer that one-to-one support. We can offer peer support groups, group work, to break down those barriers.
Yeah. There's some questions around, I guess, your role, Luke, as in how's your role funded within the service? And I guess there's a question similar, looking at how you could use a role like yours, similar in other projects or initiatives, and how you'd implement that, to have those conversations, to have that as a considered role.
Sorry, you broke up halfway through that. Sorry.
Oh, sorry, Luke. There was kind of two questions there. There was One about the kind of the funding for your role within the team, and then also how that would, you're kind of a specialist in that project that you're doing just now. How could that work to highlight the role of physical activity in other multidisciplinary teams looking at a similar role?
I mean, our clinical service manager is actually here with me, chat, so I don't know whether he'd be best to answer part of that question. But from my perspective, I joined the team 18 months ago as a 12-month secondment, almost a try before you buy, to see whether the role would work, and if it was to roll out, how beneficial it would be to the service and the impact it had on physical health.
Do you want to come in there, Steve, just around that role?
Yeah. Hi. Cheers, Luke. Thanks. Yes, like Luke says, what we actually did was we actually took one of the care coordinator posts that we had and used that as a 12-month secondment. Like I said, Luke said, try before you buy, to sort of evidence that this would work. We knew it would work, but like anything, you need to provide the data, the outcome measures, which then helps you build a business case, then to have that money recurrent. What
Oh, I think we lost Steve. Oh,
Oh,
we
sorry,
lost you a bit there.
Oh, so
Okay.
yes, so the way we're getting it implemented into the other teams within Birmingham and Solihull is because we've evidence that it works and it's productive and very beneficial to engagement and recovery and relapse prevention, is the business case that we put together now. All the community teams now are starting to replicate having a loop as part of the transformation programs, but also within the community transformation programs in the GP surgeries. There's lots of multi-agency working and business cases and plans all being put together to secure long-term funding, because the cost benefits of being preventative around the physical health conditions and weight gain and all the things that come with it is just so cost effective, but also as well what it does, it improves people's quality of life because they're happier, having fun. But actually what we do with our intervention is we look at having a laugh, enjoying it, because your approach that you have to addressing these real difficult, challenging sort of aspects around, or where you've put on X amount of weight, nobody likes to hear that. So the way that we approach that is slightly different. About, well, let's come out, let's have a bit of fun, let's have a laugh, let's do some of the activities that we have. And this is what we're trying to replicate in the other teams, is having that assertive outreach approach to engaging people, but sometimes without them even knowing that they're being engaged within this, because they're just meeting Luke as a second person alongside the doctor or the care coordinator.
Yeah, thanks, Steve. That's really important, and I think that's really interesting to see how you've approached that with this other risk in this work that isn't always highlighted. We've only got a couple of minutes left. I think just one question to pick up here, and for any of the questions that we haven't done, we will send some Q's and A's out at the end of this to cover them. But something around how you're involving family and carers in your support with these patients.
Yeah. So I can answer the first part of that if you want, Luke. Yeah, so what we do is with a lot of the physical activities, it's open to not just the service user, but their family or carers as well. Because if someone's slightly anxious to come out, okay, they know us, but they might feel a bit more sort of reassured if they've got a mum, dad, brother or sister, whichever. So we have that in the first instance, but then we look at them sort of them dropping back as then we've got more sort of input with the service users, and then with the view of them being able to go out and do things on their own. But it's a bit unique the way that we work as well. Like with our fishing group, anybody can come fishing that's related to that person, and we've got the equipment through funding and grants that we applied for. But it's very holistic. It's not just the service user and that's it, because actually what the view is then is that service users, families, carers, brothers, sisters, siblings, etc., can go and do stuff on their own once almost like we pointed them in the right direction. So I think sometimes you don't know what you don't know, do you? And if you're quite isolated, then because we'll get gym memberships that then we can get free passage, for example, for siblings and that to go along. So it's very inclusive about what we do with the service users.
Yeah. No, that's really useful, Steve. Thanks. And I see, Luke, you've just popped in the chat box that if anybody has any other further questions, they can drop you an email. So thanks very much for that. That's just almost at 11 o'clock. Just to say a huge thank you to all the speakers today. It's been incredible having you come along and share some of your insights, experiences, and your job, Luke, as well. That's been a lot of interest in what that entails. We will send out the slides, we'll send out the recording of this, and we will also send out any further Q&As. So if you have any more, you can just pop them in the chat box. And I also just want to say a big thank you to the team behind the scenes, trying to make this flow as well as possible. They've done a great job organising all of this. And we hope to see more of you again at our next webinar in January, which details will be following soon. So thanks again, everybody, for coming, and have a good rest of the day.
Thank you. Bye-bye.
Thank you.
Bye-bye.